Well, let's get started today. Thank you for joining us as we discuss an important topic that we've all been talking about for years. However, the pandemic has brought inequities in healthcare to the forefront of public health, making it even more clear that it's time to stop talking and start acting. I'm thrilled to be joined by our esteemed panelists today that represent three different organizations who are making strides in this space by leveraging at-home healthcare models to drive innovation, lower costs, and improve outcomes. We're going to hear from each of them today as to how their organizations have been advancing health equity and making an impact. But first, just some background on our panelists here. We have Dr. Julian Harris. Dr. Julian Harris is the chairman and CEO of ConcertoCare, a tech-enabled, value-based provider of at-home comprehensive care for seniors and other adults with unmet health and social needs. Previously, Dr. Harris served as president of Care Allies, a group of Cigna-affiliated population health management and home-based primary care companies. He served as an advisor to Google Ventures, focused on tech-enabled healthcare services, and led the healthcare team in the White House Office of Management and Budget as the government's chief healthcare finance officer. Dr. Harris trained in internal medicine at primary care at Brigham and Women's Hospital and served on the clinical faculty at Harvard Medical School. Dr. Harris in health policy and medical ethics from Duke University. He's also a graduate of Wharton Business School and the University of School of Medicine, where he's an adjunct, University of Pennsylvania School of Medicine, where he's an adjunct professor. In addition, Dr. Harris is an operating partner at Deerfield. Welcome, Dr. Harris. We have Dr. Maulik Majmudar, is a cardiologist and chief medical officer and co-founder of Biofourmis, a rapidly growing virtual care delivery and digital therapeutics company. Prior to joining Biofourmis, he was medical officer at Amazon, responsible for the development and launch of Amazon Halo, Amazon's first health and wellness-focused membership service. Dr. Majmudar was also associate director of the Healthcare Transformation Lab at Massachusetts General Hospital and an assistant professor at Harvard Medical School, where he was responsible for the identification, validation, and implementation of digital health solutions to improve care delivery as well as the patient and provider experience. Dr. Majmudar attended Northwestern University School of Medicine and completed his residency training in internal medicine at the Johns Hopkins Hospital, followed by a cardiovascular medicine fellowship at Brigham and Women's Hospital. He holds 2 patents and has had several publications in high-impact journals, such as Nature, Circulation, JAMA, and the Journal of Healthcare Delivery and Implementation Science. Welcome. And last but not least, we have Dr. Rob Mordkin. Dr. Rob Mordkin is Chief Medical Officer for LetsGetChecked and Chief of Urology at Virginia Hospital Center. Prior to that, he served as Director of Robotic Surgery at the Virginia Hospital Center. Dr. Mordkin obtained his BS and MD degrees from the University of Southern California and completed his residency training in surgery and urology at Georgetown University. He is certified by the American Board of Urology. He's regularly voted a top doctor by both Washingtonian and Northern Virginia magazines and has been a contributing editor for Men's Journal. As a firm believer that individuals should be in charge of their own care, Dr. Mordkin joined LetsGetChecked in 2016 and helped the company build its robust network of physicians. He became Chief Medical Officer in 2019. Welcome, Dr. Mordkin. And I will be your moderator today, Bina Thomas, Head of Strategic Partnerships at LetsGetChecked. I have the distinct pleasure of sharing the floor with our esteemed panelists. And for some context, I've spent the last 22 years of my career in the population health space, spending about 10 years at Anthem in a variety of roles, and then joining Optum soon afterwards, coming to LetsGetChecked almost 3 years ago. So let's get started here. A little bit about the organizations that they represent. ConcertoCare, just to give you a brief overview of their mission, they believe seniors and older adults with complex care needs deserve a more holistic, equitable, and compassionate approach to health and wellness. At LetsGetChecked, their mission is to empower people to take an active role in their health to live longer, happier lives. And at Biofourmis, They believe personalized, predictive care backed by artificial intelligence and machine learning is the most efficient way to optimize medical resources and costs needed for the most innovative delivery of care without sacrificing quality. Wonderful. If we can take a look at our agenda, we're hoping to have a little bit more of a conversation today, and we will be covering a few topics with each of you. The first, barriers to health equity in a modern world. The second, leveraging at-home testing to streamline care delivery. And third, health equity in practice. So I do encourage the audience to send questions in over our chat over the next 40 minutes or so, and we'll get them in and ask our panelists as we're moving along. So let's get started. Julian, we're going to start with you here today. I've always believed that it's not just important to create a great strategic framework, but to have a true impact, which you all have done in the area of health equity and social determinants of health. I'll turn it over to you, but if you could set the stage for us today and discuss a little bit more detail around social determinants of health and what the organization is doing. Dr. Julian Harris.
Thanks so much, Bean, and I apologize to folks if there's a little background noise. I'm on the road, so I'm in a cafe reporting live today, but thanks so much. So we know that our healthcare system often fails seniors and other adults who have complex health conditions, and we know that in many cases, these folks come from historically underserved groups. Next slide. The last 2 years of the COVID-19 pandemic have made it much clearer that people in communities that lack access, that people from underserved groups often have a differential burden of disease morbidity and mortality. And we've seen that in the context of the COVID pandemic. We also know that many seniors face particular challenges in that context, accessing care because of challenges with providers who are postponing or canceling needed care procedures. Next one. So at ConcertoCare, we really think holistically about addressing patients' unmet medical, behavioral, and social needs. From a social needs perspective, we certainly are very focused on food security and work with both our health plan partners and with community resources. We're available to ensure that patients have access to food and nutrition. And there's actually much greater focus in many cases in Medicare Advantage and Duals plans on food insecurity. That's been an evolution that we've seen over the past set of years. It's really promising and hopefully portends well for the kinds of ways we'll be able to support seniors over time. We know that housing insecurity can be also very difficult for patients. We actually had a recent case of a patient who had a range of complex chronic conditions like heart failure and diabetes and COPD, as well as some behavioral health conditions that he was navigating, but he faced an potential eviction from his low-income senior housing unit. And our team really mobilized to make sure that his housing was preserved, because we know how challenging it would be to manage that set of chronic conditions in the context of homelessness. Transportation can also be a challenge. And again, there are some ways that we're able to partner with a range of transportation solutions on a local level to ensure patients have the ability to get to their appointments and other kind of key areas of need from a transportation perspective. One of our goals is to enable seniors and adults who have complex health conditions to maintain their independence in their homes. And one of the ways that we do that is by ensuring that not only are we thinking about ways to support the patient, but also looking for ways to support their caregivers. We know that home safety and monitoring is increasingly important as seniors age. We had, again, a recent example of a senior who suffered some hearing loss, and in that context had some particular challenges from a safety perspective. And again, apologize for the background noise as I report live from the cafe. But we think about how do we ensure that patients and seniors have a safe living environment, and are there ways that we can also leverage technology, including remote patient monitoring, to have additional data on what's happening with the patients clinically. And finally, we know that social isolation has been an enduring challenge for seniors. In many cases, it is unfortunately in this country a part of the way that people experience aging, as families are in many cases much more distributed than they were at one time, and maybe in some other contexts. But COVID really exacerbated that sense of isolation, certainly not just for seniors, but in certain cases, in unique ways for seniors. And so we also work to find ways to connect seniors into their community, to each other, and ways to support them from a social isolation perspective. So, as we think about broadening our efforts from a social determinant perspective to also thinking about how we address health equity, one of the challenges that we face as a country is really being in a position to have the data that helps us understand where there are areas of opportunity. And so both CMS, the Center for Medicare and Medicaid Services, and a number of leading health plans are doing work in partnership with innovative providers to think about how can we go down the path of collecting the needed data, including race, ethnicity, and language data, so that we understand where there are challenges that we can address when we better understand the baseline and what the opportunity set is for improving on some of those issues that are identified through looking at the data much more closely. We and others are also looking at ways to broaden the way that we leverage social determinant screening as one of the ways that we have an additional filter to understand where there are meaningful differences and ones that we can address through a health equity lens and hopefully in a way that impacts health outcomes. And so one of the approaches that we're really focused on is trying to understand, as we collect that data, how it helps us have visibility into differential inputs and outputs in terms of clinical conditions like hypertension, diabetes, and also things like advanced care planning, where there are at times sort of different approaches or perceptions about particular communities' interest in or willingness to engage around advanced care planning. And so we want to assess that as a part of the work that we're doing going forward. So I think I'm passing the microphone now to my friend.
Great. Dr. Julian Harris, thank you for giving us a voice to this issue. It sounds like you have been intentional, purposeful in your strategy. You're addressing health equity by advancing social determinants of health. And I'll ask the panelists the same thing, but how has your model helped solve for socioeconomic gaps in care?
So I think that we all, in different ways, really try to, again, understand what the circumstances are, both at a population level for the populations that we care for, and look to leverage data to do that. But in the specifics, because our model is the home-based model, we have the opportunity to observe directly the challenges that patients are navigating. We know whether or not they're housing insecure, for example, and in certain cases, we have some unique ways to better understand the extent of their food insecurity or challenges from a transportation perspective. So we have a variety of ways kind of across that spectrum of trying to connect patients to community resources that they might not have context for. In certain cases, patients actually have benefits that are made available by their health plan they're not familiar with, that we're able to educate them about and connect them to. And in other cases, there are other supports that are available, but that they don't have context for, and we're in part helping to educate them on those resources. And then in certain cases, really sort of accompanying them on that journey to navigating the process of getting access to those resources the first time, and hopefully putting them and their caregivers in a position to do that more systematically over time with less support from us.
Excellent, great. And what about our two other panelists? Perhaps can you give some color on what model your organization has used to solve for socioeconomic gaps in care from your own experience?
Yeah, I'm happy to start, and Rob can go next. I mean, I think, as Julian mentioned, there are many different approaches that different companies take. And for Biofourmis, it happens to be around the issue of appropriateness of care or accessibility of care, right? I think, how can one deliver care in a way that actually meets the patient or customer or user where they are? I think given some of the challenges we've faced with the pandemic, and before the pandemic existed as well, which is it's very difficult sometimes for patients, underserved populations, to actually access care in the right way, at the right time. And virtual care, remote care sort of approaches are one way to address those gaps. And the second gap, which I'll talk about more in detail in the next section, is really around how do you drive appropriateness of care in terms of actually the quality of care, which is then a slightly different lens added, but still addresses the equity gaps. So that's just the one approach that Biofourmis has taken.
Yeah, and at Let's Get Checked, Bina, as you're well aware, our starting point was about reducing friction within the system from a user experience. And so what we want to do first and foremost is remove barriers to care. And I think everybody listening in or on the call has, I'm sure at some point in some fashion, touched healthcare and understands sort of the pain points of a traditional approach, whether that be from how do you schedule care, how do you even begin to understand what your access points are into care, to all of the inconveniences around actually going through that process and having to get into a clinical setting, a clinician, a physician, a hospital, urgent care, physically going there, from finding parking and paying for parking to all of the other things that come with that. And then on the back side of that, as that care continues, the other pain points associated with getting results from diagnostics, perhaps, how do you then move through that process and then get the necessary support for that? So certainly at Let's Get Checked, we have thought about it from the very beginning about reducing barriers, reducing friction points, trying to streamline it, and to use the term that Maulik mentioned, meeting people where they are, I think is probably the most straightforward way to think about that.
Yeah, that's great. Thank you. Well, Maulik, let's turn to you and hear a little bit more about how you are looking through a health equity lens first by closing evidence-based practice gaps.
Sure. So as you know, let's start transition here, which is that, as Julian mentioned, there's some real sort of meaningful and important consequences of actually not addressing the social determinants of health. And I think these are just a few of them, but there are many more. But it really does lead to some significant disparities in terms of both chronic disease onset as well as chronic disease outcomes related to chronic diseases. And we've seen that in the pandemic, how the rates of obesity, or diabetes or high blood pressure and uncontrolled high blood pressure actually leads to worse outcomes among these patient populations. So I think that's important. There's the second fact, which is undiagnosed, but in my mind, more importantly, delayed diagnoses also leads to a lot of adverse outcomes and quality of life for this patient population, where again, timely access to care does not exist, and that results in these sort of adverse events. And last but not least, there's a pretty dearth of literature on the gap in, what's called the quality gap or the evidence practice gap. It's really around the appropriateness of care. So if we go to the next slide, there's a formal definition, and really in terms of evidence practice gap, one thing to mention, just statistics wise, this is a shocking statistic, by the way, that 50% of existing evidence doesn't ever translate into practice. And that's, there was a paper published in 2003 in New England Journal of Medicine, and hasn't changed much in the last 18 years or so. And the second thing about healthcare, which is somewhat surprising and unique, is that the timelines to actually go from a discovery or proof to actually widespread adoption into clinical practice is actually incredibly long, and I would say unacceptably long, 17 years, at least what the published data shows. So we combine these two data points, 50% never make it to practice, and it takes 17 years to actually get to practice. You can imagine the quality of care that we deliver as physicians to our patients is way suboptimal. And now that's compounded by the fact that certain populations of patients don't want to get this kind of care because of the SDOH that we just talked about. So I think, again, something to keep in mind as in regards to what the pain points are, what the opportunity is to really improve care here. Next slide. So as you think about, before I get to the actual statistic, the definition, let's just define what do I mean when I say evidence-based practice gaps? And in layman's terms, really all it means is that we as a healthcare system and as a community have spent incredible amount of time and effort demonstrating the effectiveness of certain therapies. And these therapies are then undergo FDA clearance and payer reimbursement approvals to then say these therapies are not only effective, they are valuable, and they're approved. But despite all of that, physicians are not prescribing these drugs for the right eligible population of patients, and patients never have the opportunity to actually take these pills, right? And I say that because I want to separate this guideline-based non-adherence with medication non-adherence, which is again, a common phenomenon where patients don't take prescriptions as prescribed. And that also is a problem, but this is proximal. This is patients don't have a chance to take the pill, but they never even get it prescribed in the first place, right? So that's what I'm talking about. So the two statistics that are really eye-opening, and eye-opening for me as a cardiologist, where that in a complex diseases like heart failure, only 1% of patients nationally in the US are on the right drugs at the right target doses. And these are, again, all FDA cleared approved drugs with proven benefit. So 99% of the times patients with heart failure are not getting the right therapies, which is unacceptable. And it's a crime, right? So the question is like, why is that the case? So we can go through that. If you look at common diseases, things like literally 100 million US adults face today, like high blood pressure, diabetes, and cholesterol issues. This is a paper that was published 2 months ago. 42% of patients in this cohort of 500,000 patients studied did not get the right guideline recommended therapies for simple and common chronic conditions like high blood pressure, diabetes, and cholesterol. So now it goes to show you that there's a tremendous opportunity to drive improvement in care among all populations, but especially this, if you look at variability in care, this is predominantly true for patients in underserved populations, such as geographic areas where there are more issues with the stuff Julian talked about around housing, environment, food accessibility, and things like that. So again, this just frames the problem in terms of what the opportunity is. At Biofourmis, and I can talk about some approaches, and at Biofourmis, the way we've tackled this is a combination of clinical care teams that are dedicated. They're dedicated teams that address this through a remote disease management model. So it's not like you rely on the brick and mortar clinic visits to actually access care. And secondly, through automation. I think we all know that in the current environment of healthcare, it's too expensive. And if you just throw bodies at the problem by hiring a ton of pharmacists or nurse practitioners or doctors, sure, you're going to get better outcomes, but it's not sustainable or scalable, right? Especially in the world of the Great Resignation, where there's so many shortages of different skills and role groups in medicine. So what we've done is, again, one approach is to automate this and say, how can we leverage technology and machine learning and data science to literally build algorithms that take clinical inputs like your medical history, your allergies, your lab values, and the algorithm actually recommends specific therapies and specific doses for specific individuals as personalized. And we can do this automatically every 1 to 2 weeks. So you can see how you can get somebody on the right therapies within 30 days without the need for a brick and mortar clinic visit. And the great part about this is complementary. So the next time you see a doctor 6 months later, you're actually optimized. So we strongly believe that this unique approach to opening up access to care through virtual care, combined with some kind of automation to drive quality of care and standardization of care across the US, is one approach to actually closing this evidence practice gap. Next slide. And again, to go back to the point about what are the reasons these gaps exist today, there's many, right? We don't ever want to point fingers, but there are system factors, there are patient-related factors, there's economic factors or affordability. If you look at the list here, though, the three that jump out to me, this idea of access and transport, which I talked a lot about, the idea of follow-ups, right? I think LetsGetChecked got the same problem. Like people get lost to follow up all the time. Nobody closes the loop. And then there's around compliance and education and understanding of these meds. And there's authorization, right? So there's barriers sometimes even getting the drugs, so there's prior auth requirements by insurance companies. So there's a lot of these things that we can address relatively easily through dedicated teams and some automation. We can't address all the factors here, but vast majority of them can be addressed. And that's sort of one of the things we've done with our platform. Next slide. So with that, I think I can wrap up by saying that we've demonstrated in clinical trials, and this is published evidence, that you truly can make a difference in improving the quality of care and closing the equity gap. And I guess one thing we can talk about in the discussion is that when I talk about health equity, people always sort of assume always it's about access or social determinants where they geographically live, or sometimes these equities have to do with other things like technology, even connectivity. And one of the things we noticed in the pandemic was that access to virtual care was very different with patients with lack of internet access versus those that did, or the broadband, what's the speed? How can you maintain a connection even? So I think there's lots of other ways to think about equity here as well. So one of the things we've talked about is, again, just the closing the appropriateness of care, the quality gap for now.
Great. Thank you, Maulik, for also lending a voice to this, as it's been impressive to hear all the things that you're focused on. A question for you, and then I'll ask our panelists to weigh in. You've talked about different approaches that you have done to address this gap. Is there a silver bullet, perhaps? Is there one answer? Is there a one size fits all? I'd love to hear your perspective there.
Yeah, you're throwing me a question when you know the answer, right? So clearly, as Julian's mentioned, and I think you'll hear from Rod, there isn't a one answer, and we can't actually build solutions that are one size fits all, because all we're going to do is actually increase the equity gaps, because the reality is that bias comes into play in all of these different models, and you want to make sure what you're doing is really personalizing your approach and the delivery to the individual patient, whether it be culturally, socioeconomically, geographically. So I think the way I always look at this from a care model standpoint is that we have a lot of different tools in our toolkit, and you want to match the right sort of approaches to the right patient populations and be flexible and adaptable to be able to do that and not be stuck to one model, whether it be brick and mortar, hybrid, virtual, whatever have you. We need all of those models available to different patients.
That's great. Thanks, Maulik. I'll turn it over to Rob or Julian. I'd love to hear from you in terms of an example of perhaps an innovative approach within your organizations to solve for evidence-based practice gaps.
I'm sure that I can jump in there. First of all, Maulik makes great points. There is absolutely no silver bullet. We're all going to accept that. Although I would say that if there's anything close to a silver bullet, or at least a major step forward, I think, is having third-party payer, having federal programs more and more acknowledging the validity of some of these newer models in terms of telemedicine delivery. For example, if you look pre-pandemic, an extremely small amount of care was being delivered through telemedicine platforms or telemedicine methodologies, despite the fact that if you talk to frontline care workers, most of us really wanted to be able to do that. We knew the technology certainly would support that. We knew that many of our patients wanted to be able to engage with us through some type of remote platform, particularly in sort of more routine follow-up management type engagements. And yet the payer systems really weren't there. And so they weren't willing to reimburse for it. And therefore, there really was not any acceptance of it. As soon as the pandemic hit, and not only was it okay to engage in a remote way, but it actually was the only way to engage, because hospitals were being overrun with the needs around COVID. And so we needed to keep patients out of the hospitals, out of these access points. And all of a sudden, we started to see insurance and certainly Medicare, CMS supporting the idea of telemedicine financially. We've seen this tremendous uptick in acceptance. So again, while there is absolutely no silver bullet, I would say one major thing is to get acceptance on the payer side that these models will work, but it's not going to be just one model. As Maulik mentioned, it's going to be having components from all of them. And so, I think that would be my one comment on that.
Great, Rob. Thank you. Great. We can keep moving here. Rob, I know health equity is not a prescriptive strategy. Tell us a bit about how Let's Get Checked has worked to improve inequity in healthcare.
Well, I think that there are obviously, and Maulik had a really nice slide there a bit ago showing about all of the different components that sort of lead into inequities, right? I mean, it is not one straw in the camel's back, it's multiple straws, and there are a variety of reasons. Certainly one of the things that we've been able to address of that list of causes, certainly Let's Get Checked, one of the things we've been able to address is sort of the geographic limitations around this. And I think many of us are probably familiar with this sort of notion of food deserts around the US, where there is not access to, quality foods or organic foods, et cetera, et cetera. Well, the same scenario exists in healthcare as well. There are certainly swaths of this country where geographically it is very difficult, if not impossible, to gain access into a healthcare system for, routine primary care engagements. And so by certainly Let's Get Checked, with our model being able to meet the customer, the client, the patient where they are, we can actually bring that care to them. And you look at a statistic like this, you've got 65 million Americans who really don't have access or easy access to primary care. And what does that translate into? The vast majority are not getting recommended preventative health care. They're not getting their routine screenings. They're not doing their colon cancer screening. They don't know what their blood sugar or their A1C may be doing year in to year out. What's their baseline renal function? What are their lipid profiles that might be able to predict future downstream issues with cardiovascular disease? So because we can bring care to them, we can really bypass any of this issue that's created by geographic locations. If you go to the next slide, Megan, we talked before about at our foundation, one of the things we wanted to do was remove barriers to access, and whether that be geographic, but there's also economic barriers there as well. We've got, certainly in our model, a lot of price transparency. It's certainly less expensive to deliver care in a remote way once the infrastructure is built than it is, in the traditional bricks and mortar type approach. And I think, and Maulik mentioned this, but around improving the care quality by leveraging technology, by leveraging best practice standards that hopefully we don't take 17 years to get to implementation, but we move them to the front of the line. We can take that, improve the quality of care by then implementing these broadly to our populations through automation and by leveraging technology. So that's how we do it at Let's Get Checked. And I think, we're seeing the success. If you go to our next slide, I think we've got a good example of that. We partnered at Let's Get Checked with a large health plan, who had identified a big group of their plan members who are appropriate for hepatitis screening. 150,000. We were able to bring 150,000 hepatitis test kits to these individuals, and that's all happening in a very, very short period of time. Really, literally within a few days to a few weeks, these kits are in flight to the individuals, to the members. Out of that 150,000 that were screened, we found 2,600 that were positive for hepatitis C. Now that's a pretty big number when you think about the fact that those are people that, had we just continued down the traditional path, they're not getting tested. Or very, very few of that 150,000 were probably ever going to get tested. And so they're not, the 2,600 then aren't going to come to light until they have the disease sequelae of hepatitis C, which is going to present very late stage. And now you've got hundreds of millions of dollars, quite literally, that are going to be wrapped up in trying to care for these patients who are very, very late stage. And so there is a big economic impact to being able to get to these people early and test them earlier. That certainly, the first and foremost is simply the importance of, let's get them identified early, ethically, let's get them turned away from a late stage disease. But if you want to, bring it back to the financial implications, there is a tremendous amount of cost savings by phase migrating the detection early, getting the detection done to people that otherwise aren't getting tested, and getting their screening early, and being able to steer the ship off the rocks way before they're ever in line with the coastline. So that's how I view it, and I think we've really been able to do that at Let's Get Checked successfully, as highlighted here. So, what's the future of at-home healthcare? What do we believe it's the future? Certainly, Let's Get Checked is really being able for somebody to get as much of their care, where they are, and we do this certainly Let's Get Checked through a variety of ways. Certainly, first and foremost, leveraging technology so that people in a seamless way, or as seamless as possible way, can engage with their healthcare, whether that be through a web portal online or on their phone, Android, iOS app engagement. We don't believe it's just enough to offer diagnostics, although diagnostic testing has certainly been a mainstay of what we've evolved at our platform, but it's not just enough. So we've now built in our model the telemedicine component, the clinical care component, to support all of that, underpin that, or wrap around that. So not only are we then offering a diagnostic or when appropriate, but we've got the consultation around that to figure out what is the appropriate diagnostic, and then most important, or as important, how do you then guide somebody based on the result of that diagnostic? If treatment is necessary, and certainly if it's medication treatment or if it's lifestyle treatment, we can bring that to bear as well through the same platform, whether it's engaging with our dietitian, whether it's engaging with our own pharmacy. We have the ability to prescribe and e-prescribe and dispense out of our own pharmacy. We have our own pharmacist. So, Maulik was talking before about how patients don't take medications correctly, or maybe getting side effects. Well, we can engage with them in very real time. So you don't just have drop off where patients either aren't receiving their meds, they're taking them and not understanding how to take them correctly, or maybe they're taking them and getting a side effect, which makes them discard it and move on. We'd rather continue to engage with them and make sure that we're getting them the right care. And then I think one of the things that made me so excited about our model, Let's Get Checked, when I first got involved, was the notion of sort of how do you follow patients chronically, particularly if you think about some chronic disease states, diabetes, elevated cholesterol. Right now, if I were to engage through a traditional pathway and I go and my physician discovers that I have elevated, let's say elevated cholesterol, I've got to remember that I'm supposed to go back at some interval, 6 months, a year, whatever it is, and be tested again to see if perhaps the lifestyle changes I put in place are improving things or are not improving things, or is the medication I'm on moving the needle in the right direction? Well, now I've got to remember, geez, when was the last time I saw my physician? Now I've got to make an appointment. Well, we can automate that all through our model. So now your test kit shows up at your door at 6 months. You don't have to be reminded because it's literally physically sitting there in front of you. That's the reminder. And then we're going to come back again, and our clinical team is going to wrap around that, support that, and continue to engage with the individual. So it's a holistic, longitudinal, almost 360-degree approach about how we go about identifying and then monitoring and caring for these patients.
That's great, Rob. Thank you for sharing those insights. We know that health equity, this journey doesn't end here. All the literature says have the right data, understand what your patients are telling you about the services they receive. And I like to say, engage with authenticity and humility. I'd like to hear from each of you about perhaps where you see health equity in the next 5 years. And Dr. Julian, we'll start with you. Where do you see health equity kind of moving down this continuum in the next 5 years or so?
I think what's exciting is in the next 5 years, we're going to have better data. So, there's a lot of conversation that I find both absolutely necessary and very frustrating around the fact that we don't have the data to be able to ask and answer some of the questions that are so important. We're going to be in a different place. So I think that's incredibly exciting. I also think that we're going to have some evidence of people and organizations that have taken action and are actually able to sort of demonstrate progress against concrete initiatives tied to specific chronic conditions that they're seeking to impact. So that's what excites me about the next 5 years.
Great, Julian. Rob or Maulik?
Yeah, well, I was going to just piggyback on what Julian said. I think the piece about the data is that over the last few years, especially the last 2 years, we have been seeing a lot more publications around the disparities in care. And that's not just racial disparities, it's also sort of gender disparities, right? Outcomes for women are different than men. For example, outcomes in certain zip codes are different than other zip codes. So there's a lot of different areas of disparities in care. And I think they are being highlighted. So I think to me, that's like step number one. Let's uncover and understand what the actual issues are. Then I do believe because of those things and because they're so obvious and so sort of, quite frankly, embarrassing, there are real sort of solutions and real investment being made in terms of how best to approach these. Now, I do believe the reality is that a lot of it is still lip service, though. We're still early, right? We actually haven't seen any concrete results from some of these programs or policies. And the question will be, can there be efforts through both grant funding as well as sort of, the industry to actually initiate some of these care models, different care approaches to evaluate them. Because one of the things we need to do is be rigorous about the analysis and make sure that whatever we do, we study it to know that it actually has an impact as opposed to just observational data. So I think to Julian's point, when we think about data, we sort of want to make sure it's high quality data and it's not anecdotal data, and that we can actually, put our hat on and actually create policies around these data in a way that's sort of sustainable over a long time.
Yeah, it is going to change a lot, as you point out. When the data comes out, we will want to make sure that we're putting our efforts and our money and all of that in the right direction. I think the thing that excites me the most about the next 5 years, particularly as within this sort of remote care model, which I do believe the data will eventually show does help solve the problem, or at least solves the problems that we're talking about, which are these gaps in care. Is the evolution of the technology, how we're now seeing some really amazing technology that will help support all of this coming to the individual where they are, whether that be through allowing more at-home testing just beyond, obviously we at LetsGetChecked have become quite proficient in doing a lot of laboratory diagnostics. We're going to expand that suite of testing, what that means going into pharmacogenomics and some of these new technologies in the testing space. But I think there also are other diagnostic tools, around blood pressure monitoring, EKG monitoring, real time, all of that is incredible. And then imaging diagnostics as well. When we can start to bring imaging diagnostics or access to imaging diagnostics to some of these groups that we've identified today around, whether it be cost limitations, geographic limitations, but being able to put that into their hands or get them in front of that quickly, I think is going to be amazing. So, I think that technology is going to continue to really drive a lot of this forward. And as you guys both have pointed out, hopefully underpinning that with some really solid data to make sure that we're heading in the right direction and not spinning our wheels.
Yeah, that's great, Rob. The other piece of this is there's a lot of anxiety about getting it wrong, but I do think that has to be part of the conversation as well. Are there any lessons learned that the three of you would share with the audience today?
I guess there's some, so Julian, I don't know, but there's some famous examples, right? There's in literature, the last 12 months, there's at least 2 examples that have been very well publicized around bias in our EMR built-in calculators, where the historic data from the 70s, 80s, and 90s was just so biased that the entire equation we're using for kidney care or kidney health have been completely wrong all this time, right? And Julian and I grew up in medicine learning about how do you address or account for sort of African-American racial status, and it turns out that the data was just bad. And then there's another example was around pulse ox with COVID, around the use of blood oxygenation and how your skin tone and how dark it is or light it is. Some of the medical devices actually have a tremendously unacceptable high error rates for blood oxygenation. So you have patients sitting there with hypoxemia where they may not even be hypoxemic because the device is actually not giving accurate values. And FDA has cleared these because there never was a requirement historically to test ubiquitously across all populations evenly, and they were predominantly tested in sort of Caucasian populations. So there are already examples where lessons have been learned where if you don't think about this stuff ahead of time and actually plan for it, you will inadvertently create challenges in quality of care that a lot of people practicing physician may not even be aware of. So I think it's just important to just be top of mind, some of these issues.
Yeah, and I want to give a shout out to my former co-resident, Dr. Mordkin, who led a lot of the work that really, I think, brought the kidney care community to realize that there needed to be a different approach to leadership around that. But you need to have these concrete examples to point to. And it really does also sort of highlight the need to have people thinking about these issues more proactively and studying them in a rigorous way.
Yeah, I think to me, the biggest lesson learned recently is kind of the notion about when there's a will, there's a way. That you look at the pandemic and what our healthcare system was able to do when it had to do it. And I think this is just an example. This is a topic like that. If there is going to be a will as a country, as a healthcare system to improve this problem, then we will find a way through it. I think we've heard some of the solutions, or at least the potential solutions today, but this is it's not going to be a one size fits all, and it will be data driven ultimately, as Julian mentioned. So
that's great. Well, as we moved to a virtual healthcare platform, we now have technology, and that can continue to be either our friend or foe, either help us or exacerbate the issue. I'd love to hear from the three of you in terms of how have your organizations served your patients equitably, either through the use of technology or perhaps using other methods.
Yeah, maybe I can start on this one, just given some of Biofourmis' at least hypothesis, I'll just put it that way, around the use of technology. I strongly believe, on the whole, technology will be a big positive driver for improving healthcare and reducing health equity gaps, like no doubt about it. The difference is how we deploy and implement some of those solutions using technology have to be equitable themselves. I think that's part of the challenge I'm seeing now, is whether it be machine learning and AI for radiology diagnosis, or looking at technology to do remote monitoring in the home environment, or laboratory testing, or all these different things. Are all the populations getting access to these things equally, right? The opportunity to actually use these tools equally. And I think a lot of the reimbursement challenges, a lot of the, a good concrete example is like hospital at home, okay? So there's this whole new program around acute care in the home because of the pandemic and the CMS waiver. Well, it turns out that vast majority, over 215 hospitals that offer this, have a very narrow geographic footprint around the main health system where they can offer these programs. Well, who lives, in inner city populations? So what about all those rural patients and people in different neighborhoods that have to be 20 miles out? They can't even have access to this whole entire program, which is this big thing everybody talks about, but you're leaving a lot of patients behind. So I think just thinking about how do we think about these programs, sure, we have to prove it out, but being able to have a plan in place to say, how will we extend this program to all the populations that may be eligible, or actually do need it, is actually something I think, but technology overall will improve all those things. Just we have to be mindful for some of those gaps.
Yeah, I think that, it's important to kind of think about foundations, right? So making sure that people actually have broadband access. I was meeting with a leader recently who was talking about their experience in a middle income country where, in a rural village, everyone has broadband, but we somehow still have not figured that out across the country here. So that foundation is important. But virtual health, no question, can be an important part of the solution for the complex patients that we serve, as can remote patient monitoring technology. And we're always looking for ways that's targeted and evidence-based, because there's some things that seem interesting, but the data doesn't really back up the impact that we might look for. But we're excited to kind of continue to see innovation in that space.
Yeah, I think the technology is going to drive it all too, because there's no question, however we get there, it is a fact that rural healthcare right now, rural hospitals, you talk to the American Hospital Association, I mean, rural hospitals are struggling mightily around this country. The cost to operate a hospital and everything else is astronomical, and it's really further driving this disparity. Certainly geographic, there's an economic disparity that happens too, based on where these places are geographically as well. But at the end of the day, we're going to have to find solutions to meet those populations and treat those and care for those populations, because their hospitals simply, many places, no longer exist or barely exist. So I think technology will be the answer to do that through these remote approaches.
And the other thing, maybe just like to piggyback this under one of the comment being that, the other thing we should think about also from the technology perspective is not always focused on the clinical side of things, but also that's this operational efficiency side, right? And sometimes we forget, like, a lot of the challenges we have right now is partly driven by the fact that the cost of healthcare is so high. We actually can't extend to the massive populations. So one of the ways that we've thought about is also, how do you drive efficiency, the operational efficiency in these places and systems that opens up opportunity and revenue to actually then invest in some of the right things clinically, right? So I think that's another aspect of technology that's overlooked.
Yeah, that's exactly correct. That's great. Thank you. Well, tell me about a success story. Can each of you share a success story in your respective organizations that was a mission moment in advancing health equity? There could be hundreds, I know, but it would be great to hear one specific story that really resonated with you.
Julian, you want to start?
I think I shared a case earlier, but always happy to share, another one. I think we had a patient from an immigrant community who had end-stage renal disease and had some peripheral vascular disease, and this was a patient who really needed to have an amputation, and basically decided he wasn't going to have the amputation, and let his family know. They'd begun to look for burial plots for him. Sort of faithfully had come to administer last rites, etc. And we kind of think about the social isolation piece, but in this particular case, finding that right person, who in his particular case happened to be someone in his own social network who'd been through something similar. And that patient shared a story around sort of having that patient literally come to his room, in the very late stages of his condition, with his amputation, and dance for his friend, dance for his colleague, and say, there is life after this. It saved his life, first of all, but it's also just a reminder that people are navigating health challenges, on their own in many cases, without the kinds of peers or social supports that they might need to help them kind of understand what life might be like as they kind of navigate various kind of chapters of their particular condition. So that was another case that resonated pretty recently.
Yeah, maybe I can share one story here. I think the moment that I remember vividly, the moment for us as a company, as Biofourmis, was this, we had this big hypothesis and big sort of risk we're taking, thinking about how do we automate complex disease management in a way that is outside the traditional healthcare system for something as complex as heart failure. And what we learned in our clinical trial, the early stage clinical trial that we did with 35 patients, that not only were we able to actually get medication optimization done in a very safe and effective way, but we started having physicians who were part of that study, investigators, call us and tell us that they absolutely love the platform because they're actually save a ton of time when their patients are seeing better results. And they swear by the fact that they want to continue using the platform even after the trial ended, even though it was not a commercial product yet. It's like a year ago now, right? And then more important on the patient side, though, we had 3 or 4 patients write us and talk about the fact that they hadn't experienced any hospitalizations, or they actually were able to walk longer because they now are on the right therapies where they actually felt better. They actually felt better. And they're like, whatever you did, but I actually feel a lot better. And it was nothing magical. It was just like we got them the right medications. These meds work. And we went through the whole rigmarole of getting the prior authorization requirements, or going through all the hurdles that normally would have to face. But just hearing that and seeing those results, I think gave the company just a lot of sort of energy and momentum to say there's something here that we need to go prove out at a much larger scale, of course, as we're still a startup. But that, I think, was very powerful to hear those stories from both clinicians and patients.
Yeah, and Bina, I'm going to actually tell one of your stories. I hope that's okay. But
absolutely.
Yeah, and maybe I should let you do it, but I'll hop in and then you can add color. But we've certainly had plenty of success stories, and I believe many success stories that we don't even necessarily know about that are happening every day as we roll out our diagnostics broadly to a large swath of populations. But one that sort of jumped to mind here recently, it's just fresh in my mind because I think we learned about it yesterday, in fact, was somebody who had been involved in one of our presentations around our capabilities at one of the plans, the health plans, and wanted to understand sort of what the patient experience might be like, and ended up doing one of our colon cancer screening tests, our BioFit tests. And lo and behold, their test kit came back positive. And long story short, they end up, getting to a gastroenterologist, and from there end up with a colectomy. And, this is somebody who was otherwise asymptomatic, was really just trying to go through it, had never really thought about in the context of their own health, but found the ease of it coming to them and being able to do it. And then the part that to me I found so interesting, and this kind of hops along with what what Maulik was just saying, was that they had a comment from their surgeon who said, previous to this, I wasn't a big proponent of these at-home sort of types of programs, but that was previously. Now that they've kind of bought in, because they understand that that they were able to get a screening done on somebody that otherwise really wouldn't have been screened until much later, if at all. So, and I don't know, Bina, if I have the story partly wrong, feel free to add color there as you'd like.
That's exactly correct, Rob. And that was one that really hit me squarely right between the eyes. I will say, it was an 8-week journey for this individual from the time that they received that FIT test kit to having 4 polyps removed, one that was the size of a baseball and had no symptoms. So, it is why we do what we do here today. It I think drives the missions of our personal mission, and I think our professional mission. So again, thank you for sharing that. I'd like to thank the panelists for the ability to have this conversation. It's been fascinating to hear all of the wisdom that you've shared in advancing this topic forward. I think for us, we'll continue to push that needle forward. And again, thank you to the panelists. Thank you to the audience for joining us here for this last hour. On the screen here, you'll see if there's an interest, we have a discount code for about 30% of all of our testing solutions on our site, LetsGetChecked.com. If there is an interest to get that FIT kit or any of our other kits there. So again, thank you for the time. If you have further questions or comments, please do not hesitate to reach out. Have a great afternoon, everyone.
Thanks so much for having us.
Thanks. Take care.